All you want to know about optic nerve sheath fenestration. It was introduced by D. Wecker for neuroretinitis. It's a simple procedure that creates a fenestration in the optic nerve sheath whereby the target organ, that is the eye, is spared of the pressure-related effects by creating a diversion. So when is ONSF indicated? In unresolved papilledema in either IIH or CVST. Here you need to note that the only and serious complication of papilledema is vision loss and can occur in as high as 40%. The other indications are unresolved chronic papilledema in any of the above and traumatic optic nerve sheath hematoma. But remember, it is not the first line of treatment in both these conditions. So when would you operate? In cases where there's rapidly progressing visual field loss or acuity loss, which is documented and reproducible, in a failed shunt operation or when shunt is contraindicated. But one prerequisite is documentation of subarachnoid fluid on the B scan prior to surgery. Now, why are we talking about the B scan? Let's understand the flow of the CSF. Once formed, it enters third ventricle, the fourth ventricle, and finally the subarachnoid space as is shown. And note that this space is right around the optic nerve head, just behind the globe. And it is this that we pick up. Now let me highlight the role of B-scan in ONSF. This was a patient who reported with chronic papilledema. The visual fields are completely constricted, as you can see, including the macular field, indicating that this patient will definitely need an ONSF. The patient reported on Saturday and was scheduled to undergo surgery on Monday. But because of my routine of doing a B scan prior to surgery, we proceeded and note that there is no fluid at all, unlike the one that we saw on Saturday. And why is that? Because of the LP done on Sunday. And thereby, an ONSF was avoided. ONSF can be done either under GA or LA by the medial approach or the lateral approach. I shall be describing the medial transconjunctival optic nerve sheath fenestration. Please do not dilate the pupil. A 270 degrees medial conjunctival peritomy is performed by sitting temporally. The medial rectus muscle is hooked and isolated. Interlocking 6 cervical sutures are passed through the medial rectus muscle and the muscle is disinserted. Then a baseball stitch with a 6 cervical suture and interlocking bites is taken across the medial rectus insertion. Remember, this is the most important step in this surgery. The globe is then retracted laterally to expose the intraconal space. Here, first follow the long posterior ciliary artery, which takes us right up to the optic nerve, and then the short posterior ciliary arteries to isolate the optic nerve. Intermittently, you have to observe the pupil, look for a blood-free area, and make an entry with the angle keratome. Note the gush of fluid. This is the technique of optic nerve sheath decompression. Thereafter, a part of the sheath is removed, performing the optic nerve sheath fenestration. The baseball stitch is then removed. The MR muscle is then sutured back to its insertion and the conjunctiva finally sutured with 8 cervical sutures. As you can see here, a patient with papilledema having 6/36 vision in both eyes and significant constriction of fields show a flattened nerve with 6/6 vision and resolution of the visual fields. Now let me try and give you certain tips and tricks to attain the best results. Now for every patient, a pre-operative B-scan is a must because prior to doing an ONSF, we have to ensure that there is the cuff of fluid, otherwise we'll be directly slicing the nerve. Highly malleable neurosurgical retractors of various sizes are used for this. They can be folded or bent the way you want to enter and fit into narrow spaces. In addition, we also use the cotton peanuts. A 10 to 15 degree angle keratome is used. This helps make a flap which can be excised and you can get a good fenestration. The baseball stitch is very important. This straddles the medial rectus. It helps visualize the optic nerve better by a good maneuvering. It is similar to the reins of a horse and helps retract the globe. As you can notice here, it helps us to keep a watch on the pupil simultaneously so that intermittently we can give relaxation to the optic nerve. Use neurosurgical patties. These are used as retractors to push the fat on either sides. And in addition, you can also use the cotton peanuts to give you the same. Here you can see the neurosurgical patty have nicely pushed the fat away, expose the optic nerve head, and you can easily go ahead and do the decompression. Now, is there a role of ONSF in atrophic papilledema? Let's look at this gentleman who came from Iran with a 6/18 parts vision in the right eye and finger counting 1 meter in the left eye. He had atrophic papilledema. In spite of the 6/18 parts vision, there was a complete constriction of the visual fields. This is the 10-2. However, what you will notice here that the OCT of the optic nerve head is fine, but that doesn't indicate there is no swelling. It in fact indicates that the nerve is actually dying. So what we need to then look is the B scan, and note here the amount of SAF around it, and the optic nerve head size was as high as 6 millimeters. Anything more than 3.5 is significant. In view of the significant fluid around the nerve, we plan for an ONSF. As you can notice, the optic nerve sheath is so enlarged that it can be seen even without retracting the baseball stitch. And with one go, see the amount of fluid gushing out. Then we have done a fenestration. Then with the help of blunt scissors, we break any adhesions underlying the sheath. Now, if you compare the change in the SAF from the day of surgery to 4 days, you will notice that the SAF is completely removed, which means that subsequently the optic nerve head will also resolve, because this is the first sign to go. And due to the axoplasmic stasis, it takes some time for the other part of the optic nerve to flatten, which can be anywhere from 4 to 6 weeks. This gentleman has now stable vision for the last 6 months. So what is the ideal timing of ONSF in IIH or CVST? It depends on the visual loss. If it's severe, you do it before, shunt can be done later. If there is moderate to severe loss, you can do it along with the shunt. If there is only moderate loss, shunt is done first. If there is no resolution of fluid after 6 weeks, you go ahead and do an ONSF. And in mild cases, you do not do an ONSF. For systemic symptom like tinnitus, headache, CSF diversion procedures are required, not ONSF. So to summarize, ONSF is a safe and effective method to preserve or even improve vision loss secondary to papilledema due to raised intracranial pressure. A good coordination between the neurologist, neurosurgeon and ophthalmologist is a must. Remember that vision loss is the only and severe complication, and it's only an ophthalmologist who can make a difference and salvage the vision. And this video will aid any ophthalmologist to be able to perform this procedure with ease and also guide them as to when and how to do it.